I'll be discussing the treatment planning for anal and rectal cancers. I'll start by my screen here. I'll start by briefly going over some of the contouring and setting up your plan for VMAT, continuing more in detail with the 3D and VMAT planning, and then how we evaluate our plans when we know it's ready to send to the doctor. And at the end, I'll have a couple of example patients we've treated here at Stanford. So there's a few organs at risk we're concerned with in this area. The small bowel is usually our highest priority, but we also have the femurs and bladder, and especially for low rectal or anal cases, the external genitalia will also contour. And the bowel will usually draw as a bag structure. In other words, anywhere bowel could potentially be. But in some cases where we have it overlapping with our target, we may carve out and underdose just the loops instead of the entire bag as shown here. And it's good practice to do a quick review of your contours before planning and after the doctor draws their volumes. There's a lot of auto contouring software in the field now, and while it saves time, there are some structures that are often underdrawn or overdrawn, or might have holes in them, and you might need to touch up. And unfortunately, one of those that it commonly happens is bowel. So I'll be honest, I deleted the slices on top of the bowel here, as you see. So I can't blame this on the auto contouring software. But the point that I wanted to make here was to be sure that to verify your organs at risk are contoured on all your PTV slices as well. So many of our anorectal cancer patients are sent prone on a belly board device, as shown here. If the patient is somewhat mobile and able to tolerate, this position gives us better sparing of the small bowel. And this position is particularly helpful when we're treating with the 3D technique, where we're unable to carve out the high dose from the bowel as we would for VMAT. But even in VMAT or IMRT plans, we can further push down the bowel dose compared to what we're able to with them laying supine. And this was a study that evaluated the impact of this positioning on small bowel dose. They simulated patients in both positions and compared the bowel dose, as you see in the graphs here, black being supine and red being in prone being in red. And it's also illustrated here at the top right, showing the greater amount of bowel in blue overlap with the PTV45 in yellow in the supine position. And then in addition, it showed that the interfraction dose variation to small bowel was similar in both prone and supine. So for 3D planning, even though it's not often the preferred technique, we'll still use it pretty frequently since it can be difficult getting insurance approval for IMRT, as Dr. Poland mentioned. But what we commonly use is the 3-field geometry. So we'll have a PA field with wedged laterals and the heel of the wedge towards the PA field. We'll use higher energies to help with hot spots and getting the dose at depth, and then 1 cm MLC margins for shaping the dose. But more recently, we've been using a software called EasyFluence that automatically creates your field and field segments and field weighting. So here you can see the target, your predicted dose coverage or distribution, and you can select which target you want coverage to. And you're also able to limit your number of segments and minimum MU per segment here on the left. And for this, we use about 5 or 6 MU, and I think for the number of segments, 4 usually. But overall, we've found this saves a lot of time with our 3D plans, especially for breast planning, as I think Jonathan mentioned in his last talk. So our goals are much the same as they would be for VMAT, as they are for 3D. We want at least 95% coverage of our PTV. We try to reduce to 105%, and it's nice to have the global max in the GTV, but I know that can be trickier to accomplish with 3D. VMAT still gives us the best conformality, but with 3D, you'll have less integral or low dose throughout the rest of the body. But this was a plan that was also created by EasyFluence, and you can see the auto-generated segments here on the right. So before we get into the planning portion, we want to make sure our optimization structures are what we want. We separate our low-risk PTVs from the high-risk, and we want to make sure our OARs don't overlap with our targets. The reason we do this is that it will prevent conflicts between objectives when we go to optimize the plan. To help us, we'll use what we call tuning structures. You also hear them called opti structures or optimization, but they're basically copies of the original structures that we'll use in optimizing so that we're not making edits to the original PTV or OAR. So in the video here, we have our PTV 54 in red, PTV 45 in blue, and the distance that we carve away depends on the dose difference between the two targets, and we'll use a 3 gray per millimeter rule of thumb. So a 9 gray difference means that we'll have 3 millimeters of separation between the PTV 54 and 45. And then for controlling low dose, or dose outside the PTVs, a lot of us find that the ring structures work best. An example of something we might use is shown here as like an inner ring that will limit the high dose, and that's 5 millimeters from the structure, from the target, and an outer ring to limit the intermediate dose that's cm.5 from the target. And also we'll sometimes draw a avoidance sector in the anterior to prevent low dose bridging anterior to the bladder or help reduce bowel dose even further. Then we'll also create tuning structures for any OARs that are overlapping with our targets and we want to underdose. So for example, here we have the bowel overlapping with our PTV 54. And since we try to keep the bowel dose max less than 54, we'll need to carve this out. So we'll create 3 separate structures. We have the bowel subtracted from the PTV, a separate overlap structure, and then the PTV subtracted from the bowel, all cropped maybe 2 to 3 millimeters away from each other. But this overlap structure then allows for better dose control in the area, so I can meet the bowel constraint, but at the same time not push it as much as the bowel outside of the PTV. And then it's also important to crop any targets 3 millimeters from the skin, unless it's a situation bolus, because as we know, it takes a few millimeters to build up dose at the surface. So when normalizing to a volume that's too close or even outside the body, it can cause your plan to be unreasonably hot. Tuning structures could also help a lot with preventing dose bridging. This is useful in a lot of our plans where we're treating the inguinal nodes. And so we'll draw an avoidance area between the two volumes. These are used a lot in our bilateral head and neck plans to prevent dose bridging over midline. But as you can see here, it's able to separate the 70% dose line in pink. So when setting up for our VMAT, we'll typically use somewhere between 2 to 4 arcs, depending on the size and complexity of our PTV, partial or full arcs. If we're not treating those, sometimes you can get away with a couple of partial arcs across the posterior. With our collimator angle, we use somewhere between 6 and 3 degrees, but you want to have at least some angle, maybe a minimum 5 degrees, to reduce any interleaf leakage. mentioned in the previous talk, or one of the previous talks, the more perpendicular your collimator angles are between fields, the more freedom your MLCs have to shape the dose. So it's important in situations where you're needing to carve out a complex structure, or you want to prevent dose bridging, as we saw in the previous slide. So for this plan, we're treating the anus plus nodes. It was a very large PTV that required 4 arcs. We used 10x, which is what we use for most of our pelvis plans. And then we have our perpendicular collimator angles, but it's also split left and right, as well as sup and inf. And the reason we do this is because we limit our X-jaw, as circled here. And this might be something unique to varying and eclipse users, but it's recommended that we keep an X-jaw limit less than 15 cm for our VMAT plans. It's still possible to optimize with X-jaws that are wider, but your MLCs won't have as much freedom to shield dose, so you might notice them getting stuck when moving across the field. We do utilize jaw tracking, as seen here, which helps in reducing the low dose, but unfortunately does not fix the issue of the jaw width limit. And then one thing to be aware of when using the prone belly board is couch clearance. Even though your plan most likely will be midline, the device does lift the patient off the table quite a bit. So you want to be sure your isocenter isn't placed too high or posterior in the patient so that the gantry angle may collide with the couch underneath. This chart is something that I've used for a while. It was on an older machine with a wider couch, so it's on the conservative side. But I know if my isocenter is midline or at 0, then a table height of 20 or less will be adequate for clearance. If it's a different plan that has a more lateral PTV, let's say your isocenter is 7 cm off midline, then you would want a 13 cm couch height or less. But I want to emphasize that this is dependent on your couch vendor or type. So I wouldn't use this before testing on your own machine. But if you're able to use this or something similar, it can save planners time from going out to the machine for collision checks. And once we're comfortable with the geometry, we can begin the optimization. So on the left side, we have our objectives, upper and lower, and they'll show up as carets on your DVH here. And you can watch your dose distribution on the right. We have our MR stages at the bottom. We'll go through all of them. But one thing I'll point out is I'll focus on my target coverage in MR1 and wait until MR2 before putting our priorities for organs at risk or rings. And I like to keep an eye on the cost function to the right. This can be a way to identify conflicts within the optimization. Our targets should be at the top of this list or the highest priority, but if the structure's taking up too much of the cost, like this bar is filling up here, it's telling me it's not able to meet the constraint, or I'm pushing on my rings too much, or it's possible that I put a limit on a structure that's overlapping with the PTV and I forgot to crop. But all of these issues can be highlighted here, and so it's a quick visual tool that can be handy. And here are the constraints for organs at risk that we try to limit the anal and rectal plans. And I've also included what we use for the short course radiotherapy that Dr. Pullum mentioned. And then here's some additional ones that we're treating higher up into the low abdomen. So once we have the final plan, our goal is to have 100% of the dose covering 95% of the PTV and then 100% of the GTV. And with the VMAT plans, you can improve the homogeneity by converting the hot spots or cold spots to a structure. and giving that an objective in the optimizer. But with the hotspots, it can really help with reducing the 105. And of course, we want to make sure that all our constraints are met if we're able to push down the bowel any further. In the lower dose range, we want to see good conformality, so little to no dose streaking. Here I'm looking at my 60% or 50% isodose lines, hopefully seeing them curve around my critical structures. Did I go too far? Go ahead and skip a slide. Finally, I wanted to go through a couple of cases of examples that we've treated. This was an unfortunate patient that had a large anal mass protruding from the perianal region, as well as, lymph node involvement. The planner designed a half cm custom bolus to go over the tumor. And just in the last couple of years, our physics team has been able to 3D print these, which can be very useful. So more easily conforms to the patient anatomy, so therefore helps with setup reproducibility and reducing air gaps. And there we go. And then this is a patient that was stemmed with the genitalia resting to one side that ended up being over the inguinal area that we wanted to treat. And in general, anytime you can move a critical structure out of the way, it's ideal to take advantage of. So in this case, after being discussed, it was communicated to the treatment team to tape the penis up midline for each fraction. And as you can see, the planner carved it out of the body here, add a little bit more tissue to the middle and put a hard constraint on that area. And you can see another tuning structure that was used for the dose bridging. So a few things I'll leave you with. To take time out to review contours before planning. Prone can reduce bowel toxicity, and tuning structures such as rings can help in optimization. And that's all I have. Thank you for your time.
Thank you, Jeff. That was very comprehensive review. Thank you. I will open the floor for discussion and questions. Any questions from the audience? I guess I'll ask a question about the prospect trial. So it made a big splash during ASCO meeting, and there were a lot of articles. For example, in New York Times, the article kind of slammed radiation altogether and talked about detrimental effects of radiation for rectal cancer patients. And I was just wondering about your take on it, and how did your patients react to these articles?
Yeah, I mean, I think the key things to stress is that it's just for a very favorable subset of patients. A lot of the rectal cancer patients at Stanford, we already discuss not doing radiation for them, and those are kind of the higher rectal cancers, so like the rectosigmoid, the lower risk patients. So it doesn't really it wasn't that big of a change in terms of our practice. So I would stress, it's for a very favorable subset of patients with rectal cancer. For patients with more, advanced higher risk rectal cancers, I would not recommend omitting radiation. As we discussed, recurrence in the pelvis can be very morbid. And then the other thing is, it's just interesting trying to interpret this in the age of non-operative management. Honestly, I have a lot of patients who would rather not have surgery. than not have radiation. So they actually want to escalate their chemotherapy and radiation in order to be one of those complete responders so they can avoid the surgery. And it's funny, at tumor board, sometimes the surgeons are the ones that are arguing for trying to avoid surgery, and I'm arguing, trying to avoid pelvic radiation. So like we're kind of arguing to avoid our respective treatments, but we kind of are familiar with the side effects of radiation as well as the side effects of surgery. So I think it's those are the main things. It's a favorable subset of patients, and then you really need to figure out with the patient what they would prefer to avoid, surgery or radiation.
And any comments from your patients, for example, regarding these articles in New York Times?
Yeah, no, it's interesting. No, not for this one, but I don't know if you all recall, a while ago in the New York Times, there was the article about the MSK study where everyone treated with an immunotherapy had their cancers completely go away. And so I've had a lot of patients reach out to me about that, but unfortunately we have to explain it's only like 5% of patients that have the specific mismatch repair status that would make them eligible for this treatment. So most of them, aren't eligible.
Thank you. Excellent. Any other questions?
Good day. I am the Shepard radiation oncologist from Kyiv. Thank you very much for very interesting lectures. Now we also check up and follow up the patients who avoid surgery after radiation therapy and chemotherapy, and also we saw good result and completely response after that. But my questions about the use brachytherapy, then you treat the rectal cancer, because we had experience for use combined external beam radiation therapy plus chemotherapy, and after that second phase it's brachytherapy. And we also had a good response and patients avoid the surgery. What do you think about this case?
Yeah, that's great. I mean, I probably want to learn more from you about the brachytherapy, because that's not something we routinely do here. I know the studies have shown really great rates, high rates of clinical complete response with the brachy boost. We just do our boosts like with external beam. So, instead of the 50 gray, I'll take them to 54 gray. And with short course, we have a trial where instead of 25, we give them an additional 5 gray to get them to 30. So we haven't had much experience with doing a brachy boost, but yeah, the results, the published results with the brachy boost have been really promising. So yeah, maybe that's something we can learn from you guys.
Which institutions do the brachy, Archie? Do you know which institutions?
Yeah, I don't know off the top of yeah.
Thank you very much. Thank you.
Good day, dear colleagues. I'm Marina Sokolovska from Kyiv, and I want to continue this question actually, because in case of low situated cancer in the rectal, what's our strategy when the surgery is impossible? Is it boost external, or as it was asked previously, brachytherapy? What we have to do in this case?
Mm-hmm. Yeah, so here we've just done we've maximized the chemo. So, they get TNT chemotherapy, either doublet or triplet. And then we would do long course chemoradiation, probably rather than short course, just to get more dose in. And then do an additional boost, probably to 54. Sometimes higher, if they have inguinal nodes, sometimes we'll try to get that to 60. Assuming that they're not coming out. But again, we haven't been routinely doing brachytherapy boosts, but that I know places are doing that.
Thank you. And what is the optimal timing between the finishing chemoradiation and surgery, maybe endoscopy and followed by surgery?
Yeah, so here it's a little bit different because we have been advocating for doing the radiation earlier rather than later. So, you know, they would do the radiation first and then get kind of potentially up to 4 months of chemotherapy afterwards. And so in terms of assessment for clinical response, we'll usually do that like 1 or 2 months after they're finished with the chemo. If for whatever reason they're not getting chemo or they're doing radiation at the end of the treatment, we similarly wait like 6 to 8 weeks before we rescan and kind of assess their response.
Okay. And the last one question actually about anal cancer. What is the support for the patient, because it's a very complicated localization for the dermatological toxicity, and without gaps, it's very hard to achieve the prescribed doses. For example, in our practice, we use the ERTC protocol 20011 with 2 weeks gaps between the doses 36 gray, and after that, after 2 weeks, 14.4. So we achieved 59.4 grays after the whole course.
Yeah, interesting. Yeah, sometimes it's really hard to get the patients through because like a lot of them will just be very miserable in the last couple of weeks of treatment, especially with like skin issues, pain. We see them every week during treatment. We check their counts every week. We work very closely with MedOnc if they need like IV fluids to get that set up. And we actually have a derm oncology service that is very responsive. And so for those patients who I think are going to have like they're having more skin issues, I'll refer them to our derm onc service early, and they'll help us manage. And they'll usually kind of escalate the skincare to get these patients through. And then in terms of just diarrhea and other side effects, the last thing we do is break the radiation. So sometimes we have to hold their chemo. We have to hold their second cycle of the mitomycin. But sometimes they have to get admitted.
Yeah, we don't see those breaks, right, in the clinic. You don't usually break radiation.
Yeah, that's the last thing we do. Very rarely we break them. Sometimes we have, but yeah, ideally we basically try everything, you know, before we break them.
Okay. Thank you. Sergey, you have a question?
I have one more question. Thank you very much for very interesting lectures. I was wondering if your strategy in terms of PTV margins is different in prone position as supine position, since maybe the position prone is more unstable, I would say.
Yeah, perfect. So that was one of my concerns with doing IMRT prone. So, you know, if like previously, if I wanted to do IMRT for whatever reason, I would always send them supine because I was concerned about the kind of the setup with prone. But just in my experience so far with like IGRT with cone beams and the KVs, it hasn't been an issue. So my margin is actually the same. I use a 5 millimeter PTV margin for, you know, all of my pelvic cases. But yeah, I haven't run into issues where the setup with prone has been challenging.
Yeah, that's a good question. Actually, Lisa Kachnik's trial was in prone, right? So all her IMRTs were done in prone position.
Oh, really? I think. Oh, okay.
BMC, I was there.
Okay.
Yeah.
Not the anal cancer one, right? Or
Anal.
oh, okay.
Thank you.
Any other questions? Thank you so much to our speakers. It was an excellent session. So see you then on Wednesday. Next session will be on lymphoma. Bye. Have a nice weekend.
Thank you.